What is interstitial cystitis or bladder pain syndrome? We're going to refer to this as an unpleasant sensation, pain, pressure, or discomfort perceived to be related to the urinary bladder. It's associated with lower urinary tract symptoms for more than 6 weeks in duration, in the absence of infection or other identifiable cause. So this 6-week window is important because we're going to try to differentiate, is this an acute process or is it chronic? A lot of my patients come referred to me whether it's been 10, 20 years of this condition or this has been going on for 2 weeks and someone suggested this might be IC, and then we have to kind of go down that road. Let's do some more testing before we give you a label or a diagnosis. Once considered a rare condition, if you think back, IC affects men and women around the world, and estimated in the US, there's between 3 and 8 million women affected, and 1 to 4 million men have symptoms. The average age of onset is 40 years, with 25% of the patients being under the age of 30. In my practice, I do see a lot of patients coming in that 20 to 30-year-old age bracket, but we've got to remember that a lot of these patients, they're 10 to 12 more times likely to report childhood bladder symptoms. So when getting a thorough history, you might have them tell you, yeah, I do recall some of these issues going on throughout my teens or early childhood. 50% of the patients experience spontaneous remissions with a duration ranging from 1 to 80 months, and setting up that expectation, especially with a newly diagnosed IC patient, so that this is going to wax and wane, and we're going to be supportive during that time is important. 50% of IC patients have pain while riding in a car. 63% of IC patients are unable to work full time. So a lot of FMLA paperwork in the office or disability. Unfortunately, 3 to 4 times more likely than the national average to have suicidal thoughts. So asking these hard questions is really imperative. And the quality of life with these patients is worse than patients even receiving chronic renal failure or undergoing dialysis. 52% of women with IC reported panic attacks and reported depression. And IC patients pay twice as much out of pocket for direct medical care when compared to someone with another underlying condition. Excuse me. So there's no objective marker to establish between the presence of IC and BPS. We can do self-reported studies, surveys, questionnaires, symptom assessments, and then ultimately our diagnosis. In our practice and what we do on a day-to-day, we need to listen to these patients. Likely they've told this story a dozen times to different providers, and they're looking for someone to just listen. Let's be the ones to listen. Let's hear them out, let them tell the story, even if it's the 5th time we've heard it today. These patients just need someone to hear them out and believe that what they're saying is indeed true to them. So it is not known whether IC or BPS is a primary bladder disorder or whether the symptoms are secondary to a phenomenon resulting in another cause, or from another cause, excuse me. IC patients have significantly more pain, sleep dysfunction, catastrophizing, depression, anxiety, and social functioning difficulties, as well as sexual dysfunction. And we'll kind of get more into that shortly. So, types of IC. For more than a century, it was considered a bladder disease, dysfunction of the bladder wall. In the past decade, we're coming to find that IC patients can have symptoms and problems beyond just their bladder, usually in their pelvic floor muscles and nerves. So initially, we had 2 subtypes, IC with Hunter lesions and then non-ulcerated. So that was our BPS patients. With Hunter lesions, we had roughly 5 to 10% of the patients having these lesions on their bladder wall, known as classic IC. It was very clear that they had bleeding and a damaged bladder wall. The other 90% had a normal bladder, yet struggled with symptoms, pelvic pain, bladder pain, and they were often difficult to treat. They had tight muscles, an injured bladder wall, and others were struggling with nerve dysfunction. So in 2015, Dr. Christopher Payne proposed the 5 subtypes, and it now encompasses that diversity of IC patients we see today. So no wonder the older treatment studies were so ineffective. They were putting patients in 2 separate categories, and it was making it difficult to really differentiate. So let's get into the subtypes. We've got type 1, the Hunter lesion. So as we discussed before, 5 to 10% of the population. The wounds in the bladder wall that when biopsied show severe inflammation. So you might have these come up with mast cells on biopsy. They can be very painful, require a strict diet and specific type of treatment. They're the only, Hunter lesions may be the only true bladder disease in the community, and in 2015 were linked with a rare viral disease or infection, the BK virus. It was seen often in renal transplant patients, but we're seeing more in cultures now with patients with Hunter lesions that BK virus is also coming up as well. So just a little more on Hunter lesions. They typically have a lower bladder capacity. Hunter lesions are known to cause intense agonizing pain as the bladder fills with urine. Traditional bladder therapies such as oral medications, bladder installations are largely ineffective. And most effective treatments typically are fulguration, laser therapy, steroid injection. So these are the patients that we're going to consider cystoscopy on and discuss further testing for. Now we've got subtype 2 bladder wall injury. These patients start after, let's say, a UTI, chemotherapy, bad diet, or chemical exposure. Because the bladder wall has been injured, urine will penetrate deeply into the tissues where it causes severe irritation. We're seeing more patients with recurrent UTIs overlapping with IC symptoms, even despite having negative cultures after these UTIs have been treated. And oftentimes it's just that injury to the bladder wall repeatedly with exposure to UTI or even poor diet has had a big play and role in this. Subtype 3, we've got pelvic floor injury. So childbirth, repetitive pelvic trauma, whether it be a fall, bicycling, a car accident, they cause the muscles around the pelvic floor to tighten around the bladder. These nerves and blood vessels where it can cause bladder symptoms and pelvic pain. Pelvic floor therapy is considered now one of the best therapies for IC, and research has found it to be more effective than oral medications and bladder treatments for many patients. However, we do have patients whose muscles continue to, despite PT, tighten, so we have to look kind of more at the bigger picture. What else is causing these muscles to tighten? Is there an underlying hip disorder, knee disorder, or long-term tension in the pelvic floor muscles? And we'll refer to that as mechanical dysfunction. So we've got pudendal neuralgia. So these patients often have muscles that are so tight or squeezing, pressing on the nerves. We have these patients known as bike rider syndrome. They often say that sitting is painful, and they can also have pain with arousal. Typically with these patients, we want to send for more testing. We're going to consider help from other specialties to treat these patients, as it might just not be one focal issue or problem causing their pain. So subtype 5, chronic overlapping pain. These patients might come in with more than just IC. We've got irritable bowel, vulvodynia, prostatinia, fibromyalgia, TMJ, eye pain. These patients have more than what we know just as their one complaint coming in. And these overlapping disorders make it difficult to treat. So typically with chronic overlapping pain conditions, it's believed to be driven by maladaptive nerves in the central nervous system and brain. In some cases hereditary, while others it might be that result of trauma or injury. It is difficult because these patients will often come to me saying, I've had someone tell me it was all in my head, or have a glass of wine and just relax. And this becomes difficult because these patients are dealing with true pain, and it might be widespread, and it's not just one issue that we're dealing with when it comes to the bladder. Rather than just talk about how they're physically functioning, it's essential to help them to relax their body, relax their mind, teach them to wind down, to decrease some of that catastrophic thinking, which will increase nerve and pain sensitivity. Teaching them mind, body, medicine, guided relaxation, meditation. It's effective at calming the nervous system and reducing pain throughout the body.